So coming up next, we have a returning speaker, Domagoj Damjanovic. Did I get it? Yes, I got it right. Okay, so Domagoj works in Freiburg in Germany, and he's works in EMS as well as critical care and pre-hospital care. And his interests include eCPR, PoCUS, education. Very much like many of us here, sort of a big overlapping set of interests in the critically unwell patient. Now, having just talked about, and I promise you that the presenters haven't actually collaborated to try and make these things run. It's really nice to see the way the threads run through the conference. But he's going to talk about the dark side of hemodynamics, and he's going to talk about Heads-Up CPR, amongst other things. So, and I said, I'll come back to you with ECMO later in the day, but welcome. Thank you so much.
Question marks. Yeah, we can start with question marks. Okay, thanks, John. Thanks, organizers, for having me again. It is such an amazing atmosphere. And I know for this, I'm going to have to skip slides in the end, but it's worth it. So thanks to the presenters until now, also for sharing their very personal experience. Matthew said words matter, and it touched me to the very bottom of my heart. And I guess when we walk away from this conference and as a presenter, you can say, I have moved my peers to some extent by sharing something personal and professional that is really, really moving. And I would love to skip some slides for that. So thank you so much for sharing this. Ian as well, presenting your own prematurely born son. And I could go on and on for hours. But now you are all waiting for what's that thing with that Heads-Up CPR? That's my confessions of interest and the usual disclaimer. And I put up that QR code for the reading type of thing so you can lean back and don't have to do snapshots of the literature. Also, during the past few years, we've had the opportunity to go on a little holiday to my beautiful home country, which is Croatia, and we're going back again. So we're back with the sounds and the waves, very much like last year. And today, we're going to talk about water and light. The sounds you are hearing are from the C organ in Zadar, which is built in the pavement there. And there is another monument also built in the pavement that is worth looking at. It is the greeting to the sun. It's a bunch of solar panels built in the pavement. During daylight, they collect solar energy. During nighttime, they give you a beautiful light spectacle. And it is meant by the artist to represent communication with the sun. We love light, right? We even like to look into it. We focus on it. And we very much focus on light red blood on the arterial side. And Sarah, I don't see you right now, but I guess you're around somewhere. You said yesterday we have an arterial pressure problem, and yes, we do. So what I'd like you to take away as some learning points today, overarching, is stop neglecting the venous side of hemodynamics. Acknowledge the role of venous return. We'll talk a bit of swine and men. So Matt, really, we did not talk earlier, but fits pretty well. We're going to talk about Heads-Up CPR and Heads-Up ECPR. Maybe we will be able to drag something out of the darkness into the light, much unlike this guy here who prefers to stay in the darkness, the famous radiologist by Dr. Glaucom Flecken. Thanks, Will, if you're watching, for the courtesy, and greetings to my wife. She's a radiologist, so Ralph. Okay, another thing that bothers us all day long in critical care, actually, and you will recognize that, is fluids in or fluids out. I've chosen the picture of a kitchen sink or a water sink on our ICU. And of course, we all know that it matters how how strongly the tap is open, how much goes in, and how much goes out again. So the outflow needs to be okay. And when the inflow surpasses the outflow, water will run over, obviously. All of you would say, nah, water, sink, no problem. I could also have chosen the image of a toilet where the outlet doesn't work. And I guess no one of us would dare to ignore this state. So, fluids do bother us. We very much care about arterial inflow. Still, we always try to get an idea how much of fluids is good for the patient in front of us. Do we keep them dry, like this here? Or do we even get an idea of when it would be good to stop giving fluids rather than drowning them? Looking at organ perfusion, yes, we still like to look at the arterial side. We equate mean arterial pressure with organ perfusion. Next level stuff is recognizing there is a central venous pressure, and it may counteract in some way the efforts of perfusing the organ from the arterial side. Now, how do we assess that? Bad news is, everyone knows, CVP is out. It's so, I don't know, 19th century. But we have other means of assessing this. This can only be a little teaser to go and learn it. Some of you may have asked about it in the PoCUS workshop yesterday, and we loved to talk about this, obviously. And that is assessing for venous axis. That is an image courtesy of the Sono ABCD network. The learning card, I have some on me. They are spare, but first come, first serve. And that just lets us know that on the splanchnic venous perfusion side, we can assess blood flow and even blood flow patterns. Why is that? The pressure generated by the heart activity is transmitted back into the venous side, depending on how well the heart works and how strongly filled the pipes are in front of the heart. That means we can look at how plethoric the IVC is, no news here, but we can even look at waveforms in the hepatic veins, further going back in the portal veins and even in the renal veins. This gives us easy to learn specific patterns that we can even score. And by taking this all together, we can get an idea whether on the venous side, in this patient in front of you, there is excess fluid. And of course, scoring is a nice thing in critical care, and some would say, who cares? At least in cardiosurgical ICU, we do care, because much of this data was generated by a working group in Canada. Kudos for that in cardiosurgical population. And it was shown to predict delirium and acute kidney injury. Too much of fluids is bad. You can look at it with ultrasound pretty easily. It's easy to learn, and you can get an idea whether you would rather stop giving fluids or even start to diurese this patient aggressively. Now, speaking of delirium, obviously, this is not only business for the splanchnic perfusion and for the kidneys. We know kidneys are divas, so who cares? It has also something to do with the brain, obviously. Too much water is bad for the brain. Not talking about other fluids here. And again, could it be that also for the brain it matters not only how well we perfuse it, how much goes in from the arterial side, but pretty much does it run off quite as nicely or not? This is something we tend to ignore in our daily business. We talk about autoregulation, we talk about the fact that the arterial pressure in sick brains. It's one-to-one transmitted to the brain tissue, and we care about, getting brain edema, focusing on the cerebral perfusion pressure, also on things like no reflow phenomena, ischemia, reperfusion injury, post-hypoxic brain swelling. Talked about this 2 years ago, and you can have a look at the talk on demand on the webpage. So then folks applied this to CPR. They said, yeah, this is also not new. Venous return matters in CPR. So let's see what this does to the brain. The story, how they then went on to do the research I will present to you, is interesting in itself. And I will leave it to you to read this. I need to skip this now. It's also going to be in the show notes. So what people actually did is they did animal research. Who here is busy with large animal research as well, or had some contact with that? Insights into the lab? Yeah, just a few hands. So knowing what is going on in such a research lab, where very many of these hypotheses we are dealing with are generated, actually. So they applied this to CPR. And what they did is they took a pig. They did mechanical CPR, obviously, for several reasons. One reason is that it's really the most feasible and most stable thing to do in an animal research lab, to get stable CPR quality, because that is a confounder for all of your other results. Then they tilted the head down. They had the pig supine, and they tilted the head, this is the head, hard to recognize, tilted it up. What they also did, they put a probe, a pressure probe, into the pig's brain. Otherwise, you cannot measure intracerebral, intracranial pressure. That means there is a considerable danger that this probe in the brain of the pig can damage them neurologically, depending on what other things you are doing in your experiment. That's going to be important later. Okay, so but what they basically did, sorry for that, they measured and they found that indeed lifting the head up, enhancing venous return, decreased intracranial pressure, and thereby increased cerebral perfusion pressure. It is noteworthy that they were using other adjuncts, they call it. And these are an impedance threshold device, some kind of anti-PEEP valve that enhances negative pressure in the thorax upon chest recall in CPR, and also a CPR device for chest compressions here with a suction cup, also enhancing chest recall, creating negative pressures. The results from all those experiments led that working group to even develop a device to automatically elevate the head and the torso under ongoing CPR. That is marketed, that has FDA clearance, so there is something to it. And this is what they found. I just said the intracranial pressure goes down, the cerebral perfusion pressure goes up. That was a landmark study in 2015. And there were many studies to follow, in animals and in humans as well. A little side note here, the papers in bold are not from the same working group. Okay, there could be some single source bias here. We did something completely different in our research. And I wouldn't be standing here talking to you about Heads-Up CPR unless something totally unexpected happened in our research lab. We did something that I don't know I would recommend to you again. We had to replicate some former data, and we had pretty much difficulties with it. When you look at the research we were doing, this is our research model, there is 20 minutes of untreated, no flow time, normothermic in pigs, 80 kilos, something like that. Then some kind of controlled reperfusion, and then they were not sacrificed, as in most animal experiments. Animals die after the experiment in deep sedation. for animal welfare reasons. They had to survive, and we looked at them neurologically upon their recovery. And from earlier results, we had a pretty impressive neurologic recovery. That is, even though they had 20 minutes of untreated no-flow time, after some kind of magic thing, they were standing, they were eating, they were neurologically intact within a very few days afterwards. And now we could not replicate these results. And we turned everything upside down to find what it was. One thing is, of course, such a research is pretty complex, and you have so many different factors here. It's not just pumping blood around with conventional CPR, but a lot of things that are measured and targeted and stuff like that. We call this controlled automated reperfusion of the whole body, CAL, and this is meant to limit ischemia reperfusion injury and to control better for reperfusion. So we looked for the survival and the neurologic recovery. Actually, the one thing that interests you and us most as resuscitationists. And looking at all that stuff, we could not replicate our results. We found some interesting neurologic defects in the animals that were not doing well. Speaking of the darkness and the light, the artist programmed the transition between light and darkness for the coming 50 years. And so they made sure there is always a change, a transition between light and darkness. Transient darkness. What we found in the animals is actually they were blind. Let that sink in. Question: how would you assess whether a pig is blind? Ideas? Not too easy. They do follow optic impulses. You just have to make sure if you're moving something that you're making no noise, that there is no air circulation whatsoever. You can find out. And we saw they were blind. They were not only blind, they had ataxia and gait disturbance. This stuff was spoiling all our neurologic recovery scores, because if we say standing is good and they could not stand, all the scores were bad. And also, if they cannot see, they cannot walk and stand properly, again, all the scores went bad. So we said, could this have something to do with rather the rear part of the brain? As we know that some of these neurologic functions are represented occipitally in the cerebellum and stuff. Could there be some stasis here during 20 minutes of no flow? What happened? Then, as I said, we controlled for every confounding factor we could imagine. We even looked at, daytimes and times of the year and everything. We found nothing. Then I met our veterinarian who was doing the earlier series, and I said, was there anything different with head positioning? And she said, well, yeah, speaking of it, earlier on, we were performing EEG also during the experiments. Now, how do you do EEG in pigs? You don't stick the electrodes. It's not sticky. You are poking them in with needles. To prevent pressure sores, the head was rested with the needles in on some gauze. Also, every now and then, we had to defibrillate. And when you defibrillate, things tend to dislocate. You know that. So did dislocate these needles. And to get them back in their position, they had to elevate the head and do some inclination every now and then. So we said, okay, sounds totally crazy, but let's just mimic this. Let's just elevate the head in the reperfusion phase of eCPR. Let's elevate the head and let's mimic that movement. And let's every now and then do an inclination, up to 90 degrees, head up. That's what we did. And we also pooled together the historic group. We looked in those who, by some occasion, did not have any EEG, and thus potentially did not have that head elevation thing earlier. So there is a little bias maybe here. And we had 21 animals lying supine, not quite a natural position for them, and 25 with elevating the head every now and then. You can imagine what this meant for our junior researchers, just having to elevate the head every now and then. Okay, this is how it looked. Here it rested, and here the head was elevated. Speaking of arterial perfusion, everything was fine. It was not only fine, it was pretty much arterial perfusion here. This is mean arterial pressure on an ECMO. That is pretty much going in. And what we found is indeed they did amazingly better upon elevating the head on an ECMO circuit, despite there had always been in every animal a venous drainage cannula in the right circulation site suctioning. Neurologic recovery was also better. The red ones are the head elevation ones. They recovered much earlier. Low scores are best, high scores are brain dead. So 84% with head elevation did neurologically better. Okay, now how does that translate to humans? Hard to say. This is the natural position of a pig. Lying supine is not their natural position. We do lie supine. It's our natural position. Looking at the brain, we need to look at the venous vasculature. And there is also some difference to humans. This is courtesy Gabriel Puzza, one of the groups who did the non-American works in this experiment. And we not only have venous drainage via the internal jugular veins, there is a prevertebral venous plexus. And maybe, just purely, guessing, maybe there was some kind of hypomocleon created here with elevating the head and draining these plexus better. Whatever, we don't know. It's just guessing. There were some human studies, and for time reasons, I promised you I will skip them. A little spoiler, they have their limitations. And the limitations are actually, it's observational studies, and it was with propensity score matching, the best thing you can actually do when you don't have an RCT. But the control groups were from all different registries, so different EMS agencies with a lot of strategic differences. And we already talked about the potential single source bias. So that led the ILCOR to suggest even against the routine use of head elevation. They said you can do your research on it, but don't do it routinely. The AHA says, yeah, you may consider it with trained professionals and equipment available. Speaking of equipment available, all of the studies were always performed not only with head elevation, but with the other devices enhancing venous return as well. So that ITD and the suction cup. They wouldn't do it without. Yesterday, we heard an interesting thing with CCSV. That was new to me. Thanks you for the learning point, Jason, and also for the new word I learned, that is MEHAL, working together to improve outcomes for the community. Okay, so Simon Carley yesterday gave you something to carry, something cheap. And I also want you to take something away. In critically ill patients, VAXes will help us to recognize fluid excess, to understand your patients better and integrate this for your patient management. Head-Up CPR is an opportunity to treat venous excess, venous congestion of the brain, but maybe and only when the arterial side is perfectly okay, as it was in eCPR. I chatted on Twitter actually with Dr. Yiannopoulos, the eCPR guy in the US with the ARREST trial, you might remember. And he said, yeah, Head-Up CPR in itself, conflicting results, But when you have a secured arterial perfusion, so what goes in is definitely enough, that is a whole different animal, and we can talk about that. And in an old ED ECMO crash episode, he even admits that he is actually in his cath lab when cannulating for eCPR, he is elevating the head just a bit. Okay, so let's make this everyday business. Let's make looking at arterial side and venous return together. Even my laundry bag reminds me of that. We have dark, we have color, and I leave you with a little nebulous conclusion here. I'd love you to stop neglecting the venous side of the circulation. Go and learn VEXUS. This is totally easy to learn, and it will help you a lot. Unsure about whether you should do Heads-Up CPR? I think I would do Heads-Up ECPR, and I have my folks and teammates elevate the head. Watch this space. I'll leave you with the references and some more light and water and sounds. Happy to take your questions.
So in my head, I've got a giraffe that's in a rest. There's a hippo coming with some pads, and I'm wondering how to get the head up. But I think you might have some better questions from the audience than I've got. Any questions? You don't want me to ask a giraffe question, I'm sure of this. Oh, is that... Oh no, you're just doing your hair. Sorry, I thought you were about to ask a killer question. So, when do you think this? I mean, because we'll be talking about eCPR and ECMO later on this afternoon. When do you think these sort of things are going to start transitioning into human trials and actually looking at those pressures and looking at those results later? Because as both you and Matt have said, the physiology is similar but very different between the animals.
Yeah, I think we already have these human applications. I mean, the device has FDA clearance, so it's already in the field. The question is, when is it going to be recommended? When will we have the data? And I think there is a point, and do we really need all of these adjuncts always together? Or are there some modulations to the whole package that we can study different? In eCPR, I think the problem with data is it's such a complex thing, and it's so hard to get robust data on eCPR. Now introducing another confounder, even if it's just head elevation, I think this will be too hard to get a trial design there.
Yeah, and I mean, I'm just thinking from my own experience of introducing eCPR into the London system, which again we will talk about later on today, but the complexities of doing that, I'm sure, in Melbourne with cheer and stuff, the complexities of building a system to do that, to then start thinking of these other things, it almost feels overwhelming. And quite rightly, I think we're looking at cardiac arrest as not a single disease, but a multitude of diseases and trying to pick the right treatment for them. But it's bloody difficult. Was there a question at the back? I saw a hand go up earlier, or am I, again, I think I'm imagining things. Right, well, okay, well, thank you so much. That was amazing. And these conversations will continue through the day.